Thanks very much to the organisers for inviting me along today. So as Caroline said, I'm going to give us a brief overview of some of the updates in airway management. What I thought would focus on is a little bit about the at-risk airway, and I'm going to show you a video clip which I think will illustrate that quite well. We'll talk a little bit about some airway adjuncts, touch on some pre-hospital anaesthesia, and then we're going to talk about pseudo-axioms, which I'll tell you exactly what they mean in a bit. So basically with airway, the priority is to get oxygen to your tissues. Okay, I think that's not rocket science really. So we need to establish a patent airway, and then once we've got that, we need to be in a position where we can maintain it. We need to give the patients high flow oxygen, and we need to be able to enable them to either breathe for themselves, or we might need to assist their ventilation. So they're basically our priorities. Now I'm going to show you a video clip. This is a very old clip, and it goes on for a couple of minutes, but it's just to illustrate a couple of points which we're going to talk on. So I'll just start this now. You can tell how old it is, I'm sure, by that's the doctor there. Okay, we'll move on. So I'm sure that you can all tell that there's a problem there, okay, and it was very apparent what was going on. So if we just play this little bit again, I know we're in quite a small group, so if you want to just shout out if you can think of some of the features in this particular clip that might make you think that this airway is at risk. Good, so he's snoring, isn't he? Good. Anything else? Effort, good. What about his effort? He's struggling? Good. Okay, so he's unconscious, isn't he? That's the first thing. He's not really responding. He's got some noisy breathing, or snoring as we could hear. He's got a Goodell airway in, and he's tolerating that without any problems, so that's got to be a bad sign as well. He's got this paradoxical chest movement. You could see that his chest, he was really, really struggling with his breathing, and that's another sign of airway obstruction. He's got a lot of swelling on his face, which shows a significant head injury. And there's a lot of blood around as well, especially on his airways and on his face. Sorry. So all those things together will make you think this guy has got a properly obstructed and potentially life-threatening airway problem. So we all know about simple airway manoeuvres, okay? And how many of those were being done for that chap? Not many, really, was it? He just had a Goodell in, and he just had his head almost in like a neutral position. And I do want to emphasise that clip is very, very old, and I know we've come a long way since then. But the ones that we're traditionally taught is the head tilt, the chin lift, and the jaw thrust, okay? And we all know that probably it's the jaw thrust in trauma that's the one that we tend to use the most, just to limit neck movement. So when patients are unconscious, it's the main issue is the tongue that falls back into the pharynx or the throat and obstructs the airway. And the jaw thrust is basically done by grasping the angles of the mandible and pulling the jaw forwards. And I've got a little video just to show how that's done. And it's amazing, even in hospital, how badly the jaw thrust is done quite often by sort of junior anaesthetists and junior doctors. But you can see there, and you can imagine inside what's happening is the tongue is being pulled out of the way to get a nice patent airway. Other adjuncts that we use are oropharyngeal airways, so the Goodell airway, nasopharyngeal airways, and you may have seen the supraglottic devices such as the laryngeal masks, which are starting to be used a lot more. But the one I want to concentrate on today for the next few minutes is basically the nasopharyngeal airway, because I think this is a really underused airway adjunct. Have you all got experience of using the nasopharyngeal airway yet? Do you tend to use it quite often?
We've got advice from ambulance service where we are that they don't use it that often.
Okay, good.
They prefer to use OPs rather than
That you use OPs, okay. So we're going to talk about some of that because it's my experience in hospital as well, people are very reluctant to use these airways and they are actually brilliant. So it's got a lot of advantages over the OP airway, okay. The main one is that if you've got someone who's got a gag reflex, you can put an MP airway in and it won't affect that necessarily, okay. But if you try and put a Goodell into someone who's sort of semi-conscious, they'll spit it out or cough or they might even vomit. If you've got patients who can't open their mouth because they're fitting, and the medical term for that is trismus, when they can't open their jaw, you can usually slide an NP airway in and sort of facilitate some sort of airway. And as I said, it's used a lot less frequently. Now, the two things I want to talk about are basically covered mainly in this particular paper, but they're to do with sizing of the NP airway and a little bit about indications and contraindications. I think that's probably what the main worry with all this kind of stuff is. So basically, we're kind of taught that when you want to size an NP airway, you look at the patient's little finger, you look at the diameter of their finger, and you sort of look at their nostrils and think, oh, will that go in? And that seems sort of fine. Well, there's been a lot of work, and actually Prof. Porter's just walked in at a good time. And this was done, several years ago, 10 years ago, where they used MRI scans of patients' nose. They took some volunteers, they've got MRI scans of their nose and scanned to see what's the maximum diameter that the nasopharyngeal air would fit in. And they compared this to the subject's little finger. And what they found is that actually neither of these sizes are reliable. Actually the size of your little finger is actually not really relevant to the inside diameter of your nostril at all. And the thing that we all think and we all get taught is it's the diameter of the airway that's important and not the length, okay? And then sort of years before that, so we're talking 20 years ago, a chap called Stoneham did quite a lot of work on nasopharyngeal airways, and he basically showed it's the length of the airway that's important. The reason for that is if the airway is too short, when it goes in the back of your pharynx, it's not going to separate the tissues, it's not going to alter the obstruction. And if it's too long, then it might go too far down into your airway, potentially, tickle your epiglottis or whatever, and then cause you to either go into spasm of your vocal cords or actually vomit and then aspirate. So you've got to get that size right, and the diameter is actually of little importance. So lots of studies have been done, and basically this is what they came up with, that for men, the ideal length was about 150 millimetres, and for women was about 130 millimetres. And this is looking at sort of hundreds of patients and looking at a lot of their anatomy. And it's quite good for us because that equates into similar sizes for Portex, and they're probably the most common ones that we use, a Portex size 7 and a Portex size 6. So we know that for women, we should just grab a size 6 to start with, and for men, we should grab a size 7. Okay, so that's the first thing. But what is also very apparent is the patient's height affects the size. Okay, so again, when they looked at all these scans, the taller you are, that distance between your nose and your pharynx is a lot longer. And it's nothing to do with diameter because the diameter is the same. So again, if you've got someone who is a tall male, you might need to use a size 8, and a tall female is a size 7. Okay. So again, if you keep sort of simple rules of thumb that you can just use, it'll help you get the right airway and make sure that you've got the right size for the patient. And finally, gender has no effect on size as in diameter as well. It's all to do with length. When we talk about contraindications to nasopharyngeal airways, what's the biggest one we're told? Fractured base of skull, okay. So we're not to use in a head injury with a known or suspected base of skull fracture, and why is that? Yeah, good, so it'll go into the brain because it'll end up in your brain. Okay, so again, that's what we're taught, isn't it? That's what we're told. And this is a scan of a nasopharyngeal airway in someone's brain, and you can see there's multiple fractures here of the cribriform plates. That has happened. But when we look at sort of patients who've got base of skull fractures or suspected base of skull fractures, they often have these clinical signs. They get this thing called raccoon eyes, which are basically big bruising over their eyes. They get this other thing called battle sign, okay, which is bruising behind the ear. And does anybody know what's dripping from this guy's nose just there? good, CSF, okay, so that's CSF, rhinorrhea, okay. So these are the three things that sort of classically happen with a base of skull fracture. Now, the problem is that when we're all on scene, it's very rare that we're going to be able to see half these things. A, probably because the light is bad, it's raining, it's in the middle of the night. Secondly, you can imagine to get that degree of bruising over someone's face, that's going to take hours to come out, okay? So, and you're not going to get that immediately on scene. And actually, when they first published all of this stuff about, it was only on the basis of two cases that had ever been reported. Okay, so this is not a common thing in the sort of the medical literature, okay? It's not something that happens kind of on a daily basis. So what I think is that we need to focus our training basically on shifting the fear of using it to basically making sure that we put it in safely, okay? And this particular letter, which again is in one of the medical journals, emergency medical journal, basically said the same thing. And it basically just said that it's this fear of us putting nasopharyngeal airways into patients' brains that are preventing us from using it. And it probably does happen. I mean, I'm going to say this. It probably does happen a little bit more frequently. It's just if it happened to me, I wouldn't be shouting out about it and telling people in the literature. So, but I think, you know, if you don't have a patent airway, that's going to lead to substandard care. So you've got to do everything that you can to help that. So they're very simple techniques to put a nasopharyngeal airway. I know you've all put them in, but again, if you just take some care to put the nasopharyngeal airway in, it can just make a lot of sense, really. So you might just want to lift the nostrils just to aid it going in. The key with the nasopharyngeal airway is to put it sort of parallel to the bottom of the nose, so not pushing it backwards, because that will encourage it to go sort of upwards, but pushing it almost straight down, and just good lubrication and a little bit of rotation just as you're putting it in. And if you stick to those simple rules, then it should work every time. Okay, so nasopharyngeal airways are good. I think they're a really valuable tool in airway management. Okay, they're a lot more useful most of the time than oropharyngeal airway. They're cheap, they're easy to put in, they're very effective, and you know you've got two nostrils to put two of them in. Okay, so that is really going to help your airway management a lot. So that's what I would say. And just remember this table as well. So 6 for women, size 7 for an average male. But if you've got a tall female, a size 7, and if you've got a very tall male, you might need a size 8. Okay, so I think they're sort of good rules of thumb. Any questions about that before we move on? Does that make sense? Okay, good. Okay, the next thing I wanted to talk on is about pre-hospital anaesthesia, because this is something that obviously as doctors we are getting involved in a lot, and it's actually increasing in frequency. So we're going to talk about rapid sequence induction and intubation, okay, and we tend to call that RSI, and I'm sure you've all heard that term. So basically we do that to facilitate rapid anaesthesia and definitive airway control as quickly as we can, okay? And we need to sort of minimise the time interval for losing airway reflexes and getting an endotracheal tube in the airway. And the main worry with all of this is when we've put patients off to sleep and they've lost their reflexes, is that they can aspirate if they've got a full stomach, and we can run into problems. This is an anaesthetic room in my hospital, okay? You can see it's very nice. We've got a consultant anaesthetist here. We've got a well-lit area. We've got an anaesthetic machine and an assistant who's trained for about 10 years. The patient is nice and pink. They've been well oxygenated. You know, everything's perfect. But unfortunately, when we're on scene, things are slightly different, aren't they? Patients' airways are usually compromised. Their GCS is down. They've got blood, vomit, debris, anatomical injuries, all sorts of things. They're shocked. You know, it's difficult to get IV access. And they might even be fitting, okay, with a big head injury. And the thing we tend to see is things like this, okay, as an extreme. And then again, we've got to do definitive airway control, and it's very, very different to the picture I showed you at the start. So, pre-hospital rapid sequence induction, okay, pre-hospital anaesthesia, is it the same as doing it in hospital? Because I tend to do quite a few of these a week in my emergency theatre, and it is and it isn't really, okay. But there are a few problems. So in hospital, things are very nice, and I showed you a nice picture of a well-lit area. But in the pre-hospital environment, we've got a problem with positioning. You know, we rely on you guys to get us access to patients. We've also got the problem with immobilising the C-spine. It's very noisy, light's an issue. Assistance, okay, we don't have quite the full team that we're used to in hospital. And equipment and monitoring should be exactly the same standards that we have at hospital. We do operate very, very strict criteria for anaesthetising patients, and I think one of the criticisms that comes with for the doctors is often, oh, you're putting too many patients asleep, and so we do work to a very sort of strict criteria, and these are the things that we do. So if patients got actual or impending airway compromise, that's very much a reason to put them to sleep, especially, you know, if we've managed to do simple airway manoeuvres as a holding measure. If they've got ventilatory failure and they're not breathing adequately enough, then they need to be put to sleep. If their conscious level is such that they're unconscious, then for airway protection, we need to put them to sleep. Humanitarian indications covers a lot of things, and sometimes, you know, we may have to amputate limbs or do that kind of stuff, and it's obviously much better if patients are asleep for that. And head injured patients, and the last one is my favourite one, which is anticipated clinical course, and that covers just about everything else. There is very good data and evidence to say that us putting patients to sleep out of hospital is actually a lot quicker than waiting for the patient to get into the emergency room and the doctors there doing it. And I think that's kind of a testament to how good our systems are in the pre-hospital environment. But certainly we know that we can be a lot slicker probably than they can in hospital, or certainly some hospitals. So the decision to anaesthetise these patients is very, very much done on a risk sort of versus benefit assessment, okay? And I don't need to tell you guys about that because that's bread and butter to you. So the biggest sort of area of sort of controversy, I suppose, is children, because, you know, to anaesthetise children, especially if you're not used to it, can potentially put them at risk. And so we'd really think quite hard before we anaesthetise children at the scene versus adults, which we do on a day-to-day basis. So preparation for this. So what we do need is 360-degree access to a patient, okay? So we need them out, we need them on a trolley, or, you know, or an ambulance trolley at a good height. We need them to be fully monitored, so, you know, as an assurance to everybody, we use exactly the same monitoring as we do in hospital, okay, down to a T. We'll do an equipment dump, you know, as you guys do, just so we've got all our equipment out. We might have drugs, airway devices, we've got some suction and stuff, and ventilation systems. This is basically just to show how we'd align ourselves, and this was a RTC on the M62 motorway, which I was involved in. And this is, we've extricated the patient who'd crashed his Impreza into the side of the motorway. We've got an equipment dump there with all of our kit. And we do need assistance, okay? So, you know, in the last picture I showed you, you can see there's a few of us around, and we ideally need 4 people, okay? That's the sort of the gold standard. We need someone who's going to actually do the intubation and do the anaesthetic. We need someone to assist us. We need someone to hold the neck and do inline stabilisation, and someone to do cricoid pressure, okay? And we'll talk about cricoid pressure in a second. So the way that we've arranged ourselves here is that that's the intubator, that's the assistant. This person's going to do cricoid, one of your colleagues, and I've got another of the air paramedics who's going to hold the neck. So before we put patients to sleep, again, you know, this will be very sort of similar to you guys. We do a talk through. So we do like a checklist where we go through everything. It allows us to give oxygen to the patient for sort of a preset time. We do all our checks. We check all our equipment and we check a position. And we do all this because we want to, our intubation attempt the first time to be the best time, okay? So we don't want to fail. I'm just going to talk very, very quickly about general anaesthesia, just to give you an overview. So the anaesthetic that we give in the pre-hospital environment is exactly the same as we would do in hospital for an operation, okay? It's no different. And anaesthesia itself is basically a combination of hypnosis, so we use hypnotic drugs, analgesic drugs, so pain-killing drugs, and muscle relaxation drugs, okay? So there's 3 of them that are a combination to achieve this bit in the middle, which basically puts you to sleep, okay? And it keeps you asleep, pain-free, and relaxed. So the drugs that we use sort of reflect that, okay? So we use a drug called fentanyl, which is very similar to morphine. It's a very, very strong opiate, and that's a very, very strong painkiller, okay? We use a drug called ketamine, which I'm sure you've seen used, which is a hypnotic agent which puts you to sleep. you also be aware that it's a controlled drug and people abuse it on a regular Friday and Saturday nights out. But we use it in anaesthetic drug doses, and when we use rocuronium, okay, which is a muscle relaxant which paralyses you. And so we give those doses. All these drugs have got milligram per kilo doses, so we have to work it out according to the patient's weight, and then we can put them to sleep. Okay, this is a clip from a TV program that was on a couple of weeks ago, An Hour to Save a Life, and this is showing MJ, one of the doctors of the London Helicopter Service, getting ready to do an intubation on scene, and the patient's asleep, and she's getting ready to put the tube in. Okay, and you can see everyone's around there. So what I thought would be useful, I don't know how many of those have ever seen inside an airway, but this is kind of a computer-generated model of what we actually look at. So when we put this is the laryngoscope, we put that in, we get the tongue out of the way with the scope, and what we're trying to do is lift it forward so that we can see the vocal cords, okay, which is the entrance to the trachea, which is highlighted in yellow just there. And that's a sort of a diagram from the side, which is us moving the tongue out of the way to get access down there. So we tend to use that thing called a laryngoscope, okay, which is a metal device. And, you know, for those of us who are anaesthetists, we use it on a day-to-day basis. But there are some sort of clever devices that are coming into the market now. And I was quite keen to sort of share some of these with you because you may see them being used in your areas. So they're called video laryngoscopes, okay? So what they are is devices that have basically got a camera on the end. And there's two in particular that I'm going to talk about. One's called AirTrack and one's called Glidoscope. And they're said to have many benefits. Okay, we use them in hospital if we've got patients who we think are particularly difficult, with difficult airways that we might not be able to intubate normally. But what the proponents will say is that you can do it with much less movement of the neck, and you'll get a better view for the first time of intubation, again, to increase your success rate. Okay, so they've got to be a good thing. So this is AirTrack. It's basically a plastic device. It's got a light switch just there, and it works on this sort of the concept of prisms. So you've basically got a prism at this side and a prism at this side, and basically it gives you a view. You can see that the ET tube is mounted on the side, and so when you've got a view of the vocal cords, you can slide the tube in. And this is a video of some Americans doing it in theatre. And you can see you put the device in, and this is what they see. So if you can just go think back to that video I just showed you, that's your epiglottis. That's the opening to your vocal cord, and they're your vocal cords. And then when you've got that view, you can just slide the tube through, and it's as easy as that, allegedly. Anyway, so the AirTrack is a good thing. It's actually sort of my favourite device. But what it does rely on is the fact that you can open your mouth, okay, because that device is quite big. And if you've got somebody who, again, has got limited mouth opening, you're going to struggle to get that in. But quite a few of the pre-hospital services are using that now, so, and often as a backup, so you may see that being used. The other one is this one called Glidoscope, and what this has got is basically a camera here and a little screen there. So again, you can see that's a similar shape to the laryngoscope. That goes into the mouth. And again, with a camera, you can see what's going on. So this is, again, this is done on a simulator, and you can see it's a similar view. So you put the scope in, you just need to move the tongue out of the way. You can get to the back there to your uvula, and then if you sort of lift up, you'll get a nice view of the vocal cords there, and you can put the tube in. Okay, so these things on the face of it look really good. And this is the guy. He's just using a stilette just to sort of straighten the tube, and you can see the tube is going to go through the cords there beautifully. Now, I am a fan of these devices, okay, in for some things, but people much cleverer than me have looked at this sort of stuff, and they've published lots of evidence. So this was a big study in critical care medicine, which is a big intensive care journal, okay, one that most of us would take very, very seriously. And they looked at AirTrack use in the pre-hospital setting, okay, and their sort of conclusion was that the learning process for this device was actually quite long and quite arduous, and actually you shouldn't be just using this if you didn't already know how to use it in the operating theatre. Which is actually in contrast to what a lot of the proponents of AirTrack would say, because they would say that if I gave an AirTrack to every single one of you in this room, 99% of you would be able to intubate a mannequin or a person on their first go. And I certainly, from my own hospital experience, don't believe that at all. So there are a few tips and tricks needed for air tracks. I don't think it's the panacea that we all think it might be. The next one is glidoscope. Okay, so this one again was from the Canadian journal, and they said that glidoscope actually improved your view. Okay, that's great. That's exactly what we want it to do, isn't it? We want it to get a great view. But what they didn't talk about in this particular paper was how successful the doctors were at getting the tube in. They got a great view, but that didn't mean that they necessarily got it in the right place. And there's another study which actually looked at glidoscope in particular, which actually said, and I'm sorry this hasn't come out very well, but basically it said that actually when doctors, this is an American hospital, when they used it with glidoscope, they actually took a lot longer to intubate the patients than they would if they'd just used a normal traditional techniques. Okay, so I think these things have got a place. I think you guys are going to start to see them used a lot more, but there are some problems with them. Okay, and certainly this would reflect my experience that it takes people a lot longer to do that. But people who are unskilled at using normal sort of traditional techniques might have some place for them. The next video I just found, and it's just to show that there are some crazy people around who do all sorts of things. And I'm not sure. So this is another type of airway device, and this guy seems to be just going around willy-nilly intubating people. I don't know, but I mean, I've never had to do that. I don't think I'll ever have to do that. But this one's my favourite. This is brilliant. I know. I don't know. Has anyone been in that position where they've had to do that? But anyway, if you ever find yourself in that position, that device works really well. There we go. Okay. So sometimes, unfortunately, when we try to intubate these trauma patients, it doesn't always work, okay, and we might fail for a number of reasons, okay, and again, you'll all be aware that sometimes we have to go for a surgical option to put some sort of airway through the front of their neck, okay. So traditionally, we used to use a cannula or a needle, and we used to put it in through the cricothyroid membrane and try and do that. I'm not going to sort of bore you with the science for all this, but basically, the problem when you put a cannula in someone's neck is that it's all right to put air in through that cannula, so you can get oxygen through, but what you can't do is get the carbon dioxide out the other side, okay? And what that is exactly due to is the fact that above, mainly at your vocal cords, if you've got any obstruction, which is usually blood or secretions, that will prevent carbon dioxide coming out from the top end. So to explain this graph quite simply is that your minute volume is sort of the amount of air that you can push in and out, and this is the amount of resistance, occlusion at the bottom. And as you can see, the more and more you occlude your airway above where the needle is, this graph comes down. So the point is, when you've got an airway that's full of blood at the top, even if you put a needle in below that, you're not going to be able to ventilate the patient well at all. Okay, so that is bad. Okay, and these arrows are all cannulas, and this is like a model. But what is good and what maintains your oxygenation and ventilation throughout is by using an endotracheal tube, okay? Because you need a big diameter, something that's going to take air in, put air in, and take carbon dioxide out, okay? And so you need something with a big diameter. And so we tend to just have a very, very quick way of doing that. We use a scalpel, some dilators, and a normal endotracheal tube, and we'll make a hole in your cricothyroid membrane, and we'll put a tube through, okay? It's quicker, and it just helps us ventilate people a lot more. And this is a gory picture of one that I did on a chap who, as you can, this is all vomit, okay? So his airway is totally occluded at the top end, and he had a rapid sequence surgical airway done to get him ventilated, okay? So, and that took about 30 seconds or less to get that in. So again, that's one sort of technique that you might see us doing. Okay, so I'm going to come sort of finally to this thing called pseudoaxioms, okay, and this is one of my bugbears in medicine. So what this is defined as is false principles or rules that are handed down through generations of medical providers and accepted without serious challenge or investigation. Okay, and I've already covered one, I think, which is the nasopharyngeal airway. There's loads of these in medicine, really. But the three that I'm going to talk about is rapid sequence induction prevents aspiration of gastric contents. Okay, because again, that's what we teach people. We say that when you do rapid sequence induction, that prevents aspiration. Okay, and I'm going to show you a little bit of evidence why that's not. Cricoid pressure. Have you all seen cricoid pressure being done during anaesthesia? No? Okay. Has anyone ever had to do it? To assist us? No? Okay, well, we'll talk about that in a second. And the other thing is about mills, okay, and stabilisation of the neck. So cricoid pressure, rapid sequence induction. So again, as I said, this is the gold standard. This is what we would all do. But actually, when you look at the evidence for RSI in hospital and actually out of hospital, there's no evidence that it actually makes a difference. If you guys were coming in for an elective operation, we wouldn't do rapid sequence induction on all of you. The main reason is that you usually fasted, so that you shouldn't have a full stomach. But even if you were, there's a lot of people who probably wouldn't. And I think, you know, I'm not saying this is sort of kind of tablets of stone, but I think that there's lots of problems with rapid sequence induction. The biggest thing is giving someone who's been in a trauma, who's probably hypovolemic, who's hypoxic, giving them a massive dose of an anaesthetic drug, and then all the complications that you're going to run into after that. You're going to get hypotension, you're going to sort of affect the blood flow in their brain. There's lots of problems that will happen. And so I'm sort of shifting my thinking a little bit away from doing this for all patients and trying to think of it on a case-by-case basis. So cricoid pressure, this is one of the things, again, is the kind of the cornerstone of RSI that we teach our juniors in hospital. Okay, and what it involves is basically pressure along the cricoid cartilage at the front here. And what that's meant to do is occlude the esophagus, okay, so your food pipe, against your vertebrae so that anything in your stomach doesn't come out and go down into your lungs while you're asleep. Okay, and you can see this is in theatre, this is someone pressing. So we wait until the patients have gone to sleep, and then we get our assistants to press on the neck, and that should help. This was first described in 1961, okay, by a chap called Selleck, who was an anaesthetist. And his initial paper had 26 patients in, and he actually had them in a head-down position. So he actually had them head down while he put them to sleep, okay, which you could imagine would encourage anything in your stomach to come out. So I'm not quite sure why they did that. But since then, it kind of got into sort of legend in anaesthesia. So Selleck described firm pressure. He never really sort of said how much pressure you need. He just said firm pressure. And what we know subsequently, that you need basically a force of between 30 and 44 newtons to occlude the esophagus. Now, that's all well and good, but if I ask one of you to press on this patient's neck with 40 newtons of pressure, you might just look at me and go, what the hell are you talking about? Okay, so this is the problem. Again, this is another thing that Selleck said in his paper, is that you should be able to teach someone in a couple of minutes how hard to press on the neck. And I don't think that's true. I think that actually it's quite difficult to work out. And certainly what I do before I put a patient to sleep is I'll get whoever's doing it to push on my hand, and I'll give them an indication of how hard I want them to press, you know, if we're going to do it. But the problem is that what we know from in-hospital practice is that it's actually done really badly by everybody, and the thing is, there's no way that we can really ascertain how well someone's doing cricoid pressure. We just have to sort of take their word for it. And even if you're using it, you still can get patients who will aspirate. Okay, and I've unfortunately had one in my career when I was a junior anaesthetist, and the patient died. So he vomited during induction of anaesthesia, and he had cricoid on. So it does happen. And what we do know is when they've done studies looking at putting patients in through a CT scanner with cricoid pressure on, the esophagus doesn't really get occluded, and what tends to happen is that you just push it off to the side as opposed to actually flatten it down and occlude it. So there's a little bit of problems with actually it working. It makes things difficult for us, okay? It makes it potentially difficult to ventilate patients, okay, in about half the patients. And actually, when we come to intubate, that beautiful view that I showed you is often distorted quite badly by having cricoid pressure. Okay, so again, it's not great, and so I personally don't really use it, and if I do use it and I run into any problems, it's the first thing that goes. Okay, so again, I think this is something that we'll probably look at over the next few years, and it might be that it becomes a bit of a change in practice. Right, the final thing is mills. So again, we talked about having mills as part of one of our sort of people in our RSI gang. We're not really sure where this came from, this manual inline stabilisation. It just sort of appeared in the Advanced Trauma Life Support Manual back in 1984. But since then, lots of studies have looked at inline stabilisation and basically how effective it is actually at keeping the neck still. So the data from cadavers, healthy volunteers, and case series. Okay. And actually, one of the big things that we worry about, and the reason that we have manual inline when we're putting patients off to sleep, is that we're worried that when we do laryngoscopy, so when we're actually intubating them, we're going to cause some problem by moving their neck and potentially paralysing them. Okay, but I'm going to show you some evidence that basically shows that actually laryngoscopy causes less movement than a jaw thrust. Okay, so you have to be a little bit careful. So this paper came out in the 90s, and they did some sort of very nice cadaveric studies looking at these things. So basically what they showed is when you do a jaw thrust, the key here is 3+. This is the movement of the upper cervical spine. Okay, so it's the first 3 or 4 cervical vertebrae. And they're saying that potentially you can move it over 5 millimeters just by doing a jaw thrust, okay, which is pretty significant, especially if you've got a fracture there. And interesting, a nasopharyngeal airway only hardly moved it at all, so that's another good reason to use MP airways. And if you put an oral tube in, it only moved it 2+, again, which is slightly less. So I appreciate it's very, very kind of flimsy data, but it just shows that actually these days we're doing things very, very safely, and we're taking a lot more attention to detail than we might have done in the past. So we'll try and limit neck movement as much as we can. And I think that this business of holding the neck is we were just not sure whether it works, okay, because there's other studies that have shown that actually it's got no effect on C-spine movement. What we're really worried about with the cervical spine is your first 3 vertebrae, okay, C1, C2, and C3, they're the ones at the top. Any fractures or anything that are below that are they're less important, they're less likely to kill you, basically. And again, if you look at some of these studies, they show that actually when you've got manual inline, it makes no difference to the movement of the first 3. It stabilizes the lower 3. So, we may be just targeting the wrong thing. So my sort of take-home message to that is that as part of things like rapid extrication and the stuff that Darren and Caroline are going to talk about, we often aren't that bothered about the neck. We're much more concerned about airway. We're much more concerned about getting patients out of the car quickly, okay, and all this stuff about inline stabilization probably isn't that relevant, because essentially if you're relatively awake and you break your neck, what will happen is your muscles will all go into spasm around your fracture, okay, and that will probably hold your neck in reasonable alignment. So I think when we ask for sort of plan A rapid extrication, we just need the patients out, and I don't think we're going to be that bothered about the necks, really. So, in conclusion, basically, we've just talked about some of the features of an at-risk airway, and I know that video clip was quite scary, and it was probably about 30 years old. I hope I've shown you a little bit of evidence that nasopharyngeal airways are good, and I take your point about the paramedics saying not to use it, but I think that we're going to have to shift our attitude in using them and focus training on putting them in safely and not worrying too much. A little bit about anaesthesia and the sort of the way that we conduct it and what we kind of need to do, and some sort of myths which I hope that we can sort of change in the future. Has anyone got any questions?